Okay.
Good afternoon, friends. It is Friday afternoon, and we are back with another episode of our FFF webinar series, The Forefront of Future Frontiers. This is a theme-based webinar series which has been going on since May 2020. And we take one theme and explore various topics under the theme and we move on. So currently we are in the series 14, that is of the theme Priority Areas in Public Health. And today we are having episode number 87. In this series, we have explored various aspects with regard to priority areas like national tuberculosis eradication, which was there, and also evidence-based organization of public health. Last week we spoke about informatics for public health. So this week we will be talking about community mental health services, which is a very important part of public health services and is one of recognized as one of the priority areas in public health. So we have with us Dr. Girish Rao. He is the Professor of Epidemiology associated with the Department of Community Medicine and NIMHANS, and he will be delivering this talk. May I request our Director Medical Research, Dr. Vishnu Bhatt, to welcome the audience and to introduce the speaker. Over to you, Dr. Bhatt.
Good afternoon to everybody. It's a very nice, wish everybody a nice afternoon. And it's my great privilege to welcome Dr. Girish Nagaraj Rao, who is a Professor of Public Health and Clinical Epidemiology at the Center of Public Health, NIMHANS, Bangalore. And he has got vast experience in community mental health. And on behalf of the management, dean, and other officials of the institute, I am very happy to welcome you here, sir. And he has more than 60 active research projects going on with undergraduate, postgraduates, doctorals, and in various levels of postgraduates. And his main areas of interest is geriatric mental health, maternal mental health, alcohol epidemiology, public health economics, and community health. So community mental health is, I think, the major work he is doing, and he is the right person to speak on community mental health. He has more than 75 publications, and if you look at the publication, many of them are related to substance abuse, alcohol abuse, and he has also 6 monographs. He is co-PI for an international collaborative project by for identifying the World Mental Health Survey in India, and he's also doing other research activities such as the socio-economic impact of alcohol abuse, road traffic injury surveillance, and he's involved in some major long-term surveys related to aging and dementia, Bangalore city area dementia study, etc., which is going on for almost 10 years. And I am sure that his knowledge and expertise will help us. Am I audible?
Yes, sir. No problem, sir.
So his vast experience will definitely help us in understanding the mental health in the community. And as you know, mental health are two basic varieties as non-psychiatrists understand. One is the people who are violent and behave abnormally, so everybody knows he is mentally not normal. But there is a large group of population who subclinically suffer, or you cannot really make out they are not able to manage the situation. And it is very important to recognize them and also help them so that they will be able to tide over the crisis. Maybe short-term problem or maybe a continuous problem. So they will require help. So with this background, I request Dr. Mahalakshmi to proceed further with regard to talk by Dr. Girish Nagaraj Rao. Back to the Mahalakshmi.
Thank you very much, sir. Before we move on to the actual talk of the day, a few housekeeping announcements for the participants. Please keep yourselves muted so that the audio quality is good for everyone. The second one is that this program is being live streamed in YouTube, and also the recording will be done so that we can use it for academic purposes posteriorly. With this, we'll move over to Dr. Rao. So the stage is yours. You can share your screen.
Are you able to see?
To see, sir. Yet to come.
Just opening.
Oh, sir, not yet.
Okay. Now is it visible?
It's not opened yet. It is saying it is started.
Yeah, it is open, sir. It is in normal mode. You need to go to slideshow mode.
Now, is it okay?
Yes, sir. You are good to go, sir.
Okay. Thank you very much. Well, I always feel myself a bit surprised when I hear the bio sketch told by someone else. Thank you very much, sir, for all that nice words. And thank you for this opportunity. As you rightly said, the myths and misconceptions about mental health is manifold. I don't think people even complete the word mental health. The word mental itself means so many things for so many, and it would indicate several dimensions. So, which is why I thought before we get into looking at community mental health services, which was my assigned topic, I thought we should look at mental health per se, and then look at mental health services, and then look at community mental health services as a larger agenda. So please pardon me if I am jumping the gun in terms of making it more elaborate. Be glad to take questions. And then once again, sincere thanks for involving me. And then greetings to all from NIMHANS. Okay, I think COVID-19 brought in a lot more changes. We were looking at a new normal. Now, one of the new normals is mental health getting into the higher agenda for many of our activities. So, not that mental health was somewhere, but after COVID, I think several people started talking about mental health. Now, that is where possibly we need to understand mental health a bit more. So, the different dimension. What else? What is mental health? The biggest aphorism what we can understand is there is no health without mental health. So, if that is the case, first we need to look at what is this health we are talking about. Well, now this is the other dimension of health. I am sure those in community medicine would understand the diagram. This is one of the earlier drafts of the diagram, which looked at health in its larger context and then said, health is something where we are born with, where we live, where we work, and possibly also where we die. So we need to look at health in its social determinants so that health needs to be placed in the context of the society where we live in. Our language also about health has changed a lot in this last century or so. I'm sure earlier we were talking about what we can say, heart disease, stroke, cancer, respiratory disease, diabetes, etc. But now we have started talking about raised blood pressure, raised blood glucose, abnormal blood lipids. So we have shifted our language. Now, possibly, I think we are also possibly on the cusp of looking at unhealthy diet, physical activity. So our language also has changed. Possibly in the future, we would be looking at the larger issues at the population level, looking at urbanization as an issue, because that gets linked up to health in a bigger way. We're talking about population aging as an issue, because aging itself in that sense could lead to how to look at health in a different way. Well, the other way which we look at health is in terms of its stress cycle. Possibly we are talking about stress being a common denominator for several of the illnesses, whether mental or otherwise, and then stress or managing stress in that sense would contribute towards a larger health, whether we talk about diabetes or we talk about hypertension or we talk about breakdown in terms of our normal health, particularly when we talk about tuberculosis. Madam was referring to it. Breakdown happens when person gets stressed out for whatever reason at different time frames. Now, this is where I would like to draw your attention. This is a slightly busy slide, which also includes psychiatry or mental health as such. But we'll come back to this slide again. But what I would like to refer is or bring your attention is, we always have been talking about primary care, secondary care, and tertiary care. But what we also need to look at is the newer definition of or newer requirement of this informal community care and self-care, which becomes very important as part of the larger pyramid of services what we are looking at. Please note, primary care is there, not that we are compromising it. Primary care sits on informal community care. We have begun to realize that much more, whether in terms of diabetes or in terms of dementia or those emerging conditions, specifically more so with respect to mental health whenever we are talking about it. This informal community care, see again, informal community care is, as it says, it's informal. Now, when we talk about community mental health services, are we looking at only the formal services of primary care, secondary and tertiary care? How is it we are also organizing ourselves to support informal community care? That's a larger question which we need to answer. I think that's where COVID gave us a lot more insight, saying that it's not just the formal health system, but the larger informal community level systems which are there, we had to dip into it. Now that is where, when we talk about community services, we need to also support this informal community care. We'll touch upon many of these things. I'm just flagging this as an agenda. The other issue which comes up is in terms of self-care. Time and again, I'm coming back to diabetes, because we have seen diabetes raising more and more. In that case, you can't continue to give medication. Medication is one part of it. We need to be talking about physical activity. We need to be talking about foot care. We need to be talking about diet management. So all this is part of self-care. So even community informal care sits on self-care, and thereby, if we look at community services for anything related to health, we have got a very large pyramid, and this new redefined pyramid is what should be our focus. Let's come back to this slide again later. Sir raised this issue of in terms of understanding mental health. The World Health Report 2001 looks at mental health being a biopsychosocial model. It has got a biological component. There is a definite age, gender predilection there. It is also psychological, because there are several emotional components which come in. beliefs and expectations which can exacerbate, which is where we are talking about stigma and tuberculosis, stigma and leprosy, which will actually impact in terms of service delivery, plus also in terms of sociological. So now we talk about mental health as a resultant of this biopsychosocial model. Okay, so in this context, if we just classify, probably top on the agenda would be mental illness. Then comes a lot of these mental health problems, which could be adjustment problems or several of these larger basket of things which comes to the doorsteps of a clinician. Now below that is psychological distress, which is the larger part of the submerged iceberg, below which would become psychosocial distress and also stress. Probably when we talk about mental health, we are talking about not just mental illness. We get confused about all these several terminologies which would affect us. More importantly, there is also this component of resilience. Should we only talk about the negative component, or possibly we need to be talking something about our reserves which are available so that any of these above things would not happen? Just like how we can say that we've got a bank balance pakka, so that would come to us at times of our need. So possibly when we try to understand mental health in its larger domain, we need to be possibly in future talk about building resilience of each one of us as individuals. Okay, just quickly going back into the definition of health. Health, as by WHO 1948, says it's a state of complete physical, mental, and social well-being. So mental health in that sense is already incorporated. Now we have got various criticisms about this because we often say that health is not a state, it is a process. But WHO again in 1977 redefined it as part of health for all, said economic and social well-being becomes part of it. Economic productivity, social productivity becomes part of our health. If we are not economically and socially productive, probably we are not healthy. Now, which is where mental health also in that sense gets redefined in terms of a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to the community at large. So possibly we are looking at a larger paradigm in terms of mental health, wherein the person's coping strategy also becomes important. If you take cancer as a problem, now, one of the issues about risk factors for cancer is tobacco use. Now, why do people start using tobacco? As a stress buster. Now, if you're concentrating only on the cancer, we are looking at only the tip of the iceberg. We need to be looking at tobacco use and also subsequently possibly looking at stress as an issue which would have contributed to the larger cancer. So in that sense, mental health is the foundation for well-being and effective functioning of individuals, families, and societies. Well, that's the larger premise which I would like to argue. But again, I have put up this definition of mental illness as per the Mental Health Care Act 2017, because all said and done, this is the legal mandate of what is mental illness. Mental illness in the very distinct sense of the Act, that is Mental Health Care Act 2017, is a substantial disorder of thinking, mood, perception, orientation, or memory that grossly impairs judgment, behavior, capacity to recognize reality, or ability to meet ordinary demands of life, mental conditions associated with abuse of alcohol and drugs, but does not include mental retardation, which is a condition of arrested or incomplete development of mind of a person, especially characterized by subnormality of intelligence. Now, this is a developmental disorder, so we need to be cognizant of this particular definition of mental illness as per the Mental Health Care Act. Well, so the new paradigm is mental health is everybody's business. It is determined by the biopsychosocial factors. It is linked to our behaviors. If you go back and then see, if it's a substantial disorders of thinking, mood, and perception, it is linked to our behavior. That is how we recognize people. Sir was talking about people become violent. That is only one part of it. But there are several issues which come up, but primarily it is our behaviors. The key thing to note is effective public interventions is possible. That is why we are talking about community level services, which is there. The collective action depends on our shared values as much as the quality of scientific evidence. If at all we are talking about supporting people with stress, I'm sure during COVID this became more of a reality. People were at home, were in isolation. They longed for reaching out to people. They longed to talk to others. So how were we able to support it? How are we able to reach out to people who either because of mental illness are isolated? Now that's a value of the society where we live in. That is where the larger context is mental health promotion. So which is why mental health plus the new public health is mental health promotion. Precisely because risk behaviors of yesterday becomes risk factors of today and will become the diseases of tomorrow. This is what we need to keep in mind. Okay, just to use on the point of the behaviors what we are talking about. This is a study which was done long time back by our department, the Department of Epidemiology at NIMHANS. When we looked at both males and females in a 4 areas, that is urban, slum, rural, and town. Now, incidentally, town is something what we are now pushing in as a separate classification. Whenever you ask anyone to do a survey, they will go to the district headquarters or further away from wherever is the metro, wherever they're staying. But that is not a rural area. That is a town or a tier 2 or a tier 3 city. That's an urban area which has got its own characteristics. So we need to be aware about these different characteristics. Okay, we took a sample from all these 4 areas, that is rural, town, slum, and also urban area, and looked at all these healthy behavior, all these unhealthy behaviors, and then classified them as whatever is their perception of being healthy or not healthy. Okay, I'll just minimize the screen. Okay, so this is among men. Now, if you look at the different behaviors which is getting reported, use of tobacco, being unhappy, not able to enjoy life, under stress, there is loss of sleep, there is sadness, abuse, violence, suicide attempting, illiteracy, below poverty line. Now, being unhappy, not able to enjoy, these are there and gets linked up to either being healthy or not healthy. Either in men or in women. The point I'm trying to stress again here is we tend to be selective in terms of how do we record behavior. We look at only tobacco, but not the other 3 or 4 components which can be asked. People do report that they don't feel happy. They are not enjoying their life. They feel stressed out. They have sleeplessness. We tend to dismiss that just as symptoms, but they do indicate the larger distress which is there in the individuals. And that is the behavior what we should be picking up. Okay, now from the same study, we looked at counting the number of behaviors. Slightly busy slide, but just concentrate on the totals, at least one behavior, at least two behaviors, three behaviors, 21.5, four behaviors, 17.9, five behaviors, 32.3. This is out of that list of 30. Any combination of behavior, 91.4%. Which just means to say, we do have a lot of these unhealthy behaviors, which we are not picking up. And that is what needs to be looked at seriously when we talk about community mental health services. It's not that we want to brand all of them as unhealthy, but they are the seeds which we need to be looking at, which will grow into a tree later in. This is another thing when we took a look at community mental health services. Complaints versus health status, again from the same study. As people had reported healthy and not healthy, but also they reported whether there was any complaints or no complaints. No complaint and healthy, good. No complaint, not healthy, possibly okay. Complaint present but healthy, we are talking about, again, complaint present and not healthy is again fine. But complaint present and healthy, these are the people who are the worried well, who will overwhelm the system. Now, these are the things which is quite bothersome for us. I am sure COVID has given a lot more insights into how we need to organize our systems. So let me quickly move on into the next component in terms of factors contributing to mental health and well-being. It could be either individual level attributes, social or environmental factors. Risk periods across the age group, because that is where some or the other issues become predominant. We'll come back to this. Okay, this is one slightly busy slide, but very comprehensive one, which talks about linking risk to mental health over the life course, which varies from adverse learning environment to family violence or conflicts, unemployment, criminal or antisocial behavior, discrimination and social inequalities, low self-esteem, which is at home and family, harmful alcohol use, also resulting in elder abuse. Now, we need to be worried about this setting and also the risks which happen to individuals over the period of their lifetime. So, in essence, mental, neurological, and substance use disorders imposes a significant burden on individuals, families, and societies. Major depressive disorders is among the top 5 causes of years lived with disability in India. Sorry about that thing. It's also GBD 2020. Results in long-term morbidity, disability, socioeconomic losses, and poor quality of life among those affected and their families. Mental health is both a cause and consequence of different NCDs, hence are predominantly considered as non-communicable disorders. Because of all these reasons, there is a need to strengthen, improve, and expand services for persons with MNS disorders. If you look at now moving into historically what has happened, just chosen because this is something which most of us are comfortable with. We'll go back to those historical components a bit later. 1930s and 40s and before that, mentally ill were segregated in mental asylums. Now that is why if you look at majority of the mental hospitals, they are always associated with a jail. In those earlier days, people who were mentally ill were considered to be put into jail. Now, at some point of time, they found that, or they realized that both the things are not related. But looking at the systems in place, what is the way they were dealing with it? They were isolated, their rights were restricted, and they were put into a asylum. But with the antipsychotic chlorpromazine coming in, which is when they found that institutionalization need not be the way forward for any person with a mental illness. We could manage these people at the community level. Now, that is where specialized centers like the General Hospital psychiatry units were initiated. Historically, it started somewhere in 1920s, but over a period of 1950s, 60s, we started establishing in each general hospital a psychiatry unit, saying that, okay, they do have psychiatry problems. They can be treated on an outpatient basis. And later, we could take them into the community as what is called as the larger movement known as ACT, or active community treatment. So people with mental illness need not be put into a mental asylum and treated as though they are jailed. Now, which is where comes the Indian contribution in terms of the Bulgari district mental health program, which for the first time identified a district level focus for mental illness and its management. I'll come back to some of these slides later. Now, the the transition period was between 2004 to 15. Till 2004, we were tottering in terms of saying, how do we expand the district mental health program? But towards 2015, more than 600 districts were covered with the district mental health program. So we have taken a leap in the period of almost a century. So lunatic asylums, these were as early as 1745. Again, this is purely because we have got historical evidence for this. 1745, 87. Primarily, we were looking at custodial management. Initially started off only for the British, but later for the Indian sepoys, and subsequently was also expanded to the general population. The growth of the mental asylums in the country is linked to this Lunacy Act in 1858. Then that is why there more of these were located away from the metropolitan city or the huge population. Over a period of time, as I said, till 1904, local population were also permitted to avail of these facilities. But the humanistic approach and early legislation change from the 1858 to the later one, when asylums were replaced with the concept of hospitals. Now, that is where is the crux. Possibly the World War I made a difference in terms of us looking at mental health in a different way. Now we were no more looking at these people as who needs to be put behind bars or jailed. We were looking at them in terms of saying, okay, they are human beings, they are individuals who have got their rights, and they need to be looked at and cared for in a hospital. So that is where in India, the first Central European hospital at Ranchi came up in 1918. And that is where the hospital concept was initiated. NIMHANS, we inaugurated the mental hospital in 1935 by the then Maharaja. So this hospital approach, in that sense, gave a total different dimension towards how people with mental illness were looked at. Now, it's not just changed into hospitals. We are now looking at that is where I brought in this concept of the social determinants. And with respect to mental health, the primary thing what we are looking at is again these social determinants. We said it need not be medicalized to that extent. We need to be now looking at a larger issue within the community and need to be looking at health promotion as a major issue. And that is why a lot of social scientists came in, psychologists came in a big way, and then patients and their families were made a part of the entire management strategy. So if you look at the medical management across the disorders, probably mental health took the primary stage and then brought in community orientation as a very first step, or you can credit mental health for initiating community services as a first one in across all the disorders. Psychiatric OPDs opened. I was talking to you about the General Hospital Psychiatry Unit, 1933, R.G. Kar Medical College in Kolkata, J.J. Hospital, Bombay, which is where led in 1946 Joseph Bohr. I'm sure all of us are aware about the Bohr Committee, who sort of placed things in the context and then said, along with mental hospitals, we also need general mental health care services, which could be brought in as part of a larger system. Post-independence, we have lesser number of mental hospitals or psychiatric hospitals, but more of community care which were brought in. Again, the period between 50s to 70s was a lot of lull in terms of what services would be brought in with respect to mental hospital. But from 1960s onwards, there is a distinct change in terms of reduction in number of beds, day hospital concept coming in, increasing outpatient services. And that is where saw the start of the National Mental Health Program in 1982. We talked about the National Mental Health Program. The Bulgari Project was sort of envisioned in 82 to 90. When we found that, again, the district of Bulgari is about 300 kilometers from Bangalore, 300 to 350 kilometers, where we said medical officers and health workers from primary health centers were trained to identify people with mental illness, initially with severe mental disorders and subsequently other minor mental disorders or non-severe mental disorders. And the care could be provided as part of the district health network. And that is why it served as a model for the National Mental Health Program. Provision of 6 essential psychotropic drugs were made part of the system. Epilepsy for historical reasons also were included as part of this. Now we are beginning to make a change there. A simple system of mental health case records were brought in, monthly reporting, and district health team was formulated. So in that sense, along with other disorders, now mental health also was given the recognition of looking at a district level system for mental health care. The psychiatrist ran a mental health clinic at all these things. They could also have a provision for admitting patients, and a review was brought in. Unfortunately, or rather fortunately, it had to wait till 1996 for a formal rollout of this district mental health program, because it took almost a decade from conceptualize to. This is what is the bane of public health. We need to be looking at the delay which would happen before when evidence is available, but when evidence gets converted into action. However, all said for better, 25 districts were identified as the pilot project in 1996. For political reasons, 2 more districts were added, so it became 27, and then was initiated. And research, IEC, and then added along with that is research. This Dmhp, NMHP was reviewed in 2003. Redesigning of Dmhp along a nodal institution. Medical colleges were attached to each one of the Dmhps so that it could become more comprehensive, so that medical colleges also would get strengthened, and the mental hospital were considered as tertiary care centers, and then they could be designated as centers for excellence, and central and state mental health authorities were designated in that period. I know this seems a bit more nebulous, That is why I thought I'll take you through the Dmhp in Karnataka, which would give you an insight in terms of how this community mental health services got rolled out. In 1992, government of Karnataka initiated uh, the pilot projects, but 2004, it was spread into 4 districts: Chamarajanagar, Shimoga, Gulbarga, and Karwar. 2015, it was expanded to 8 other districts. 2016, expanded to all districts, and also with Bangalore city as one independent district. Now, that is where Karnataka, in that sense, because of this, again, took back the leadership in terms of mental health care, trying to look at a comprehensive mental health care across the different domains. We'll just try to touch upon individually. So 2004 to 15, 2015 to 16, and 2016 to 17 covered the entire state. Now, these are 7 staff working in each DMHP. This is a national plan which is there. 1 psychiatrist, 1 clinical psychologist, 1 psychiatric social worker, 2 nurses, 1 record keeper, and 1 ward assistant. So 7 staff, 1, 2, 3, plus 2, 5, 6, and 7 for each DMHP. So totally more than 210 staff were appointed. Now, one biggest achievement of the DMHP in Karnataka is we deliberately chose that these DMHP staff are the mobile teams. They are mental health team on wheels, because if they get tied up to the district hospitals, they would become more clinical oriented and then would get tied up with all the duties and responsibilities of what would happen in the district hospital. We wanted these teams to move away from the hospital into the community. So these are truly community mental health teams. Now, there are several models which are coming up across the country. We are promoting, we are advocating for this community model for DMHP. Tamil Nadu, I think, is still looking at district hospital plus a community outreach which is being done. There are advantages and disadvantages. We need to look at it. So primarily, the clinical services of DMHP, I've deliberately not given the latest statistics. This is slightly older for reasons of proprietary. We are looking at outreach camps. Now, the DMHP teams go to individual talukas. I'll come to this concept of what we have defined as Mano Chaitanya program. Mano Chaitanya program is patterned on the fixed day strategy of service delivery. Immunization program, I'm sure all of you know that it's on Thursdays. Antenatal care is on Mondays and Fridays. So we said, why not a day for mental health? Now, that is where Mano Chaitanya program was inaugurated on October 2nd, October 10th, 2014. October 10th is World Mental Health Day. From 2014 onwards, Mano Chaitanya clinics were initiated. That is, the same DMHP team on a designated Tuesday will travel around to all the talukas or the sub-district level and conduct camps. So the psychiatrist is going into sub-district level and providing services. Simultaneously, in the other public health facilities, primary health center and secondary health centers, there are clinics conducted, and in case services are needed, they are referred to this Mano Chaitanya clinics at the taluka hospital level. So that we establish this continuity of care across the primary, secondary, and tertiary level. This is one successful program running as of latest for the last 3 years. More than 10 lakh footfalls we have been noticing in Karnataka, and that shows that goes to show that once you make services available, people will definitely take services. The uptake of services will be possible. Along with that, comprehensively Manasadhara program, again a government of Karnataka program, because you can treat a person with mental illness, but especially for severe mental disorders, they require some sort of supported care, which is what I was talking to you earlier about the social determinants. Now, that transition from acute care into the community care requires a bit of support. Now that is where a 3-month window or duration is kept in these under the Manasadhara program, which is primarily run by NGOs with money given by government, so that soon after they continue with the treatment. The psychiatrist or the team can come and always have a consultation with them, but they focus more on vocational training. They focus more on social training so that they are supported for their recovery, and thereby we are trying to improve their resilience. The next component of this is in terms of Dawa and Dua program. I think Ramanathapuram district in Tamil Nadu again is well known. I think that's when first we started. It started in Gujarat, then also adapted in Tamil Nadu Ramanathapuram district, and then now it has become a program. We also have adopted. Now the Murgmala Dargah has given a funding for opening a new facility, building a new facility. In these dargahs, many of the places, people with mental illnesses are dumped. They just leave them there and then go off. Which is also combine the dawa so that people will get better faster. Primarily, these are people with distress. Primarily, these are people with anxiety related problems. Primarily, these are people with mild to moderate depression. Many a times, even if we feel a bit depressed, we go for many of these issues, but it continues to stay. And that is where this Dawa and Dua program will always support the larger concept of health promotion. This is another component in terms of on consultation training as part of DMHP in Karnataka. We found that many of the primary health center doctors are trained, but they have not confident of providing medication for there are several reasons. So this is a new thing which came up, wherein the primary health center medical officer is supported with online consultation. The training happens, both the PHC doctor will ask a question and then make a diagnosis. Then the team from NIMHANS will get into a consultation and then ask them, okay, you have forgotten to ask this question. If you had asked this question, probably you would have picked up a lot of psychosomatic problems in that individual. So you don't need to go on prescribing anti-pain medication or simply continue with vague medications so that or the placebo care, but really address what is the issue of the individual. Somatization as a mental as a larger gamut of distress is well known in the Indian context, or for that matter, global context. This is the next component, e-monitoring of DMHP. All programs had got a website and had got a software. Why not mental health? And that is why we provided this e-monitoring software with a very minimal investment. So that sitting in one place, we were able to identify how many cases were coming in, and also we were able to initiate corrective measures for it. We also linked up the DMHP program with the regular system. Now that is where many people would not come back for treatment. So that is why the community nurse went to their individual households and inquired, and then in case medication was required, they were able to provide the medication. It was possible because we were monitoring individual patients. Well, I'm sure you would recognize the individual. Celebrity endorsement is always helpful. It works both ways, but majority, it's up to us in the health community to use it for a larger positive purpose. Deepika Padukone came to NIMHANS in 2014. I think I didn't put up that slide. And she agreed to be the brand ambassador for Government of Karnataka, particularly for managing depression. Now we have added a new component to this, in terms of now we are defining in a Taluka mental health program. In India, for the first time, we have looked at appointing a psychiatrist and a social worker in each of the talukas. These 10 talukas were selected based on either the load or in terms of further away from the main center, so that from district mental health program, we move on to a taluka mental health program. What we are looking forward, we are looking at an urban mental health program, and we are looking at IT portal for mental health care management solutions in future, and then expanding tele mental health program. I'm sure you would have heard about the union budget announcing T-Manas, that is telemedicine Manas, which will now being rolled out as a program. Shortly, we are looking at it. Hopefully, it would become a full-fledged program by 10th October, the World Mental Health Day. Now, last point in terms of the slide, this couple of more slides. For a very long time, we did not have. Yes, madam. Another 5 minutes, I should wrap it up.
There was a disturbance, so please go ahead.
Okay. Since post-independence, we were not having the actual data about mental disorders. We were always working with some thumb rules. Now in 2015-16, a very systematic effort was made to look at mental morbidity in a standardized manner in the 12 states of India, which covered nearly about 2/3 of the population of the country. And then we found that any mental morbidity was of 10.6%. The psychoactive substance use, primarily alcohol, was about 4.6. Tobacco use disorders 13.1. Schizophrenia, sir was referring earlier, schizophrenia and other psychotic disorders is a very smaller number, 0.4%. Whereas mood disorders and depressive disorders, primarily depressive disorder, is about 2.7. Anxiety and stress related disorders is 3.5. So we were able to bring in new evidence to the table saying that possibly we are looking at a wrong thing. We need to reorient ourselves into, that is where as a second component, I'll come back to that point. The second thing, despite all whatever we have done till this time, we have not made a dent in the problem. This is 2015. 15 is the date when we did the survey. The treatment gap for several of these problems remains high. We're quite happy that government took up this results very seriously. And now all the districts in the country have been covered with a district mental health program, and sincere efforts are being made to see that the program is energized. So the NIMHANS 2015 confirmed that mental disorders are a significant source of morbidity in India, significantly affects quality of life. The risk groups are in the productive age group. There is high prevalence of mental disorders among the elderly. Among females is greater than men, depression, postnatal period. The women come to the health center at least 7 to 10 times. But we fail to recognize a mental health problem or a psychological distress in the mother. And it is a huge missed opportunity. Poverty, low levels of education are closely related. Epilepsy and intellectual disability continue to be the public health problems. Treatment for mental disorders remain high. What NIMHANS identified new was the new triple burden of mental health problems. Common mental disorders are a huge unrecognized source of problems. Diabetes and depression, hypertension and anxiety. We treat hypertension, but don't look at how to manage anxiety among the individuals. We treat diabetes. We know that compliance becomes low. we don't recognize the depression among the people with diabetes. If we are able to identify depression among those diabetes, probably management of diabetes also becomes easy, and then the compliance will increase. The outcome also would be better. Severe mental disorders are equally important because they cause a significant disability, but we cannot afford to neglect it. There is a very high prevalence of disorders due to alcohol and tobacco. It is the elephant in the room, and we don't recognize that elephant there. We just say alcohol, we cannot do anything about it. There are strategies which are possible. This is the new triple burden of mental health problems which we are looking at. Variations in prevalence exist at regional and state levels. You cannot have a single straitjacketed strategy. Each district, each state has got their own set of problems. We are able to generate state level data. I will not trouble you with that. It's available on the NIMHANS website. You can always go to India NMHS at nimhans.ac.in. You'll be able to get the full reports. You need to have a regional strategy. You need to have a strategy for each state. High suicidal risk is an increasing concern. Moderate risk 0.9%. If you add the severe risk of 0.5%, it comes to 1.4% of the population. 1.4%, mind you, are either at moderate to severe suicidal risk. What is it we are doing? That is what is the biggest gap when we talk about today's topic. Mental disorders are high in both urban and rural areas. We always say everything is in rural area, but urban mental health is a big issue. There are not adequate infrastructure for health. What about mental health then? Children and adolescents continue to be vulnerable. The biggest thing what we have found is 3 out of 4 persons with mental disorders have significant disability. One or more, either in work or in social life or at personal level. They are suffering and they continue to suffer. The last point is economic burden of mental disorders is huge. On an average, the median expenditure is about 1,000 rupees per month. 1,000 rupees per month is a luxury for several households. We need to be, it may be as simple as even the transportation costs, may not be the medication costs. Now, we need to be cognizant that this is what is the burden which we are talking about. This is my last slide. We know what is there. We know what needs to be done. We need to start moving into how do we see that we deliver things better. What needs to move the mountain is not just knowledge generation. It needs to have that political linkage and the social movement which will go together. We can hope for a Spider-Man and a Superman combination coming in, but not sure who will come to our aid unless we make that effort. We are very happy that we have been able to move or start moving the mountain. The Dmhp, which is being announced by the central government, is one ambitious thing because we are building on what we found in COVID and also in our earlier effort at the National Mental Health Survey, so that telemedicine services for mental health as part of a larger gamut of services becomes possible and would be a reality in future. So let me stop here and take questions. Thank you very much. Sorry, I think I have exceeded that limit of 40 minutes. Kindly pardon me for that. I'll stop sharing so that...
Yeah. Thank you very much, sir. I think the best slide in the entire lot was the last slide. As Bruce Lee says, no, knowing is not enough. We need to apply. Being able to do is not enough. Actually, we should do it in practice. And just having the knowledge base or having the political will is not enough. But we need to gather support from the masses. I think that was the highlight of today's thing. I have one or two questions before we take it up. One is you were showing this treatment gap one slide, no, sir? Just a few slides before the last one. The bars you showed is the people who have received treatment or the people who have not received treatment. Like for example, you showed
people who have not received treatment. That's
okay,
the gap.
because it looks a little scary. Like for example, I was seeing depression. 83% is not getting treated. It's bad numbers. What we are looking at, and all the peaks were quite high. So that is what was.
Which is what, madam. See, people.
Which was what was very surprising. 83% doesn't get treated at all is quite a high number. It's almost like a very massive silent epidemic going on in the country. Very shocking numbers. That is the thing. And the other thing which when we talked about organization of healthcare services, especially community-based healthcare services, the two models we normally describe. So one is you're talking about taking the services to next level. Like what was offered in tertiary care can come to secondary level, what is offered in secondary can go to primary, and what is offered in primary can go to community health level. That is one model of what you showed as district mental health program and the taluk level program. The other model which is coming up in many of the academic institutions across the world is upskilling of people. In the sense, the best example I can give you is the Prasad Eye model, where they actually train community optometry people to pick up problems in the community. So has anything been done with regard to mental health on that level, sir?
Yeah. See, in fact, the technical words what is used for that is task shifting and role shifting.
Okay.
So both the things have been done, which is why the DMHP model is in Karnataka has achieved both. Which is what I was saying. The Tamil Nadu model, in that sense, is looked at role shifting. Or so in Karnataka, what we have done is, apart from conducting these outreach camps in taluka hospitals, the doctor, when they go to that particular taluka, also talks to the ASHA, conducts a training program to the medical officers, conducts orientation to the Zilla Panchayat or Gram Panchayat members. So in that sense, which is where I was saying both these things have been achieved by the district mental health program. Definitely the possibility is there. Now each state should be looking at how to roll out the DMHP in their particular state and the district. Hope that answers your question.
Yeah, sir. Thank you. I didn't know the exact word for it.
Very specific example. We are now rolling out Matru Chaitanya as a program. Several states, for example, I was talking about the RCH program. RCH program is one of the largest funded program anywhere in the world. Even so in India, much of our healthcare services is more for the reproductive and child health program. Now, women come to the health center. Now, if the ANMs are recognized, are empowered to recognize with just two questions, the WHO WULI questionnaire, 2 questions plus a third question, I'm sure they would be able to recognize much more. So we are building in this sort of services wherein the specialist moves towards the periphery, and people in the periphery are enabled so that they will be able to look at and then refer people, or more importantly, support them for continued care, which is why we are now looking at supporting the health and wellness centers so that the resilience also can be built up. Physical activity is one issue. Now, it is helpful for diabetes, it is helpful for hypertension, it is helpful for depression also. So physical activity need not be told only at the district hospital or in Taluka hospital. Every ASHA worker should be talking about what is the right physical activity which can be done. That's the model which we are looking at.
Thank you, sir. There is one question in the chat box from Dr. Vishnubhat. This Mano Chaitanya program, which you said that weekly mental health programs being done in PHCs, is that model followed in almost all the states, or it is only Karnataka specific, sir? Because we are aware of immunization, pediatric, maybe NCD clinics running in our PHCs, but I'm not very sure that this is universal in the country.
It is not done. See, okay, Mano Chaitanya is done on Tuesdays in Karnataka. We are pushing for this. Fortunately, the naming got is as Super Tuesday clinics. Probably at that point of time we had the US elections and Super Tuesdays were supposed to be something. So somewhere everyone became very thrilled about using it as a Super Tuesday. But we had a logic there. Now what we are trying to push in is we have submitted this model to government. Now what has happened is Dmhp, various states are looking at it in their own manner. Some of them have fixed it up as Wednesdays. Some of them are looking at it as combining with the antenatal clinic days. But as a concept, it has picked up. But as a day, it has not picked up in the way we wanted. Now, just to add to that point, if you look at it, this is just mental health. We also have neurological disorders. Headache burden, nearly 62% of the people suffer from headache. That 25.4% of the women or general population are affected with migraine, and majority of them are women. Now, you can't afford to look at only that. And there is a lot of commonality between mental and neurological disorders presentation. Stroke is also very high, and hypertension as a risk factor for stroke is more. So we are now looking at what is called as a brain health initiative under the larger rubric of NCDs. So Tuesday would be Mano Chaitanya's day, and then Friday would be the brain health clinic. So Tuesday, Friday, Jugalbandi, in that sense would give us a good gap between one visit to the second visit, because finally you're looking at the same primary health center doctor who would be rolling out the program. Brain health clinic is permitted has been sanctioned as a pilot project in 3 districts in Karnataka. It was announced in the month of March. We should be rolling it out. We are now engaging Niti Aayog, looking at dialoguing with them so that brain health also becomes an important concept. And this Tuesday and Friday becomes a sort of a norm across the country. Which is why I wanted to use this opportunity to say, please engage with us. Let's dialogue, collaborate, and wherever use your influence to see that this fixed day strategy becomes a reality.
I think there is lesson in our for our rural health centers and all in this what you had told. Other question is, this is very impressive. So the way this program is organized and various initiatives that Mano Chaitanya and one more Mano Sadhana, some step down kind of.
Manasadhara.
Manasadhara. Okay. So those programs, were you able to sustain all these initiatives during the COVID time? So how was these services impacted by COVID?
Yeah, see, that's been a biggest lesson. See, Mano Chaitanya programs did not suffer. Mano Chaitanya clinics continued to happen. Manasadhara suffered because movement of patients was prevented. So they could not come to the center. But Mano Chaitanya program was not affected because of COVID. Now, in fact, it got another dimension, which is why T-Manas has become much more vibrant now. Government of India has accepted that as a national program now. Both NIMHANS and Government of Karnataka started telemedicine in a very big way. Telehelp lines, counseling lines. We built on that so that all our patients were contacted and then services were provided uninterrupted. Now, wherever medications were required, since we had the list at the ASHA worker level, we were able to see that medicines were made available to them. So in that sense, COVID did not have a significant impact on the mental health care services. In fact, it got strengthened.
We'll ask Dr. Vishnu Bhatt if he has any comments, feedbacks, or questions further. Over to you, sir.
It's a very interesting talk, and I think he has done a lot of work and quite impressed. I was very much impressed by not only the talk but also the work done. But the one question I have for you is that you require large number of psychiatrists. So number of psychiatry postgraduate seats are very few. are we taking any interest in increasing the number? Of course, NIMHANS may have very large number, unlike other places. So, any activity is done in this direction?
So two things as a response. One, yes, the shortage of psychiatrists are there. I would just qualify that with shortage of psychiatrists in the government service. Because if you look at, there is a maldistribution of the psychiatrists or rather mental health professionals because they are more focused or they are more situated in the urban areas. So there has been a concerted effort by Government of India and also NIMHANS to look at Scheme A and Scheme B, wherein centers of excellence are identified and they are given support to start these postgraduate courses. Lot of water has flowed. There are many number of greater number of psychiatrists who are coming in, but we don't want to look at mental health program as a psychiatrist program. Mental health program is, as I said in the first slide, it is a health program. There is no health without mental health. So if you look at in that sense, we are trying to proactively reach out to all the health staff, all the, not just the, plus also the primary health center doctors and the specialists and the ASHA workers so that they can identify distress at an early stage so that this gap or shortage of psychiatrists is not felt. Any clinical quote unquote, as WHO says, encounter should include one question about mental health. That's the goal which we are moving towards.
I think that will be the right direction to train the people. Another problem may be what I'm generally thinking is that the social stigma attached to psychiatric illness. The moment somebody says you have some psychiatric problem, they are not like it. So maybe training the public health workers may help better complaints with that. Maybe one thing. Other than that, many people may not come forward to tell that they have a problem. See, that is another issue. So, are you making any efforts to check the people who are not complaining?
Yeah. So that is what the two populations are there. One is the worried well, who worry themselves, may not be sick in that, may not be ill in that sense. They are sick, definitely. And the second is those who are really ill but not taking treatment. That is where is that huge treatment gap. And this huge treatment gap is primarily because of stigma. Now, over a period of time, we all health professionals have added to that stigma rather than reduced it in any way. So after Deepika Padukone declared herself that she was depressed, there was a flurry of people who wanted to declare themselves as depressed. So it has made some dent. It has improved the number of people. Now, the issue is also in terms of how we label people. Now that is where we are looking at this brain health clinics. So they might say that they accept that they have got diabetes. A decade back, they were also frightened that or stigmatized that they would not like to say that they have got diabetes. The half sugar, no sugar, less sugar people were very hesitant to declare themselves. Now, if you don't demand for less sugar or half sugar, then possibly they look at you with suspicion. So in that sense, things have changed with respect to diabetes. We need to also move towards with respect to depression. Possibly we are also banking on calling these brain health clinics, which would be much more acceptable to people because there is a biological basis for it and they wouldn't get into the past sins or my disability, etc. All those personal connotations would not get into the illness. That's an effort which is ongoing.
Even in other places, I used to see that patients will come. Doctor, can you request the psychiatrist to see me somewhere else, not in the psychiatry department? Because suppose you tell them to go to NIMHANS, they may not go. But you go to BMC and see a psychiatrist, they may see.
Yes. Yes.
So this is another issue which is, those who are coming to NIMHANS may be brought by relatives or friends. who think they are not behaving all right or there is some problem. So this may be another issue. I think we are only seeing the tip of the iceberg, not the real thing, because whatever we do, there is a lot of people who are not really looked into. It requires a lot of manpower, and I think that's what you have rightly said.
Yes, sir. Are media to be blamed for that? Because our cinemas never ever show a person with depression. They always want a person with a bipolar disorder who is very violent. And that is just 0.4%, sir, or even lesser. If you look at bipolar, it's just about 0.2% as compared to 3.5 with anxiety or 4. Totally, that's about 8%. There is a larger thing which people, and whenever someone asks for mental health, mental illness, they talk only about those having a dagger in hand and out to kill people. That image should get changed.
Thank you, sir, for that very engaging discussion you took us through. We sure would like to host you at some other point of time in physically also inside the campus. We'll work towards that, sir. With that, I think we'd like to thank Dr. Girish. Actually, I have no personal connection with Dr. Girish. We actually wanted somebody to talk about community mental health services. So I spoke to Dr. Meena, who is in education department in your NIMHANS, and Dr. Sri Ganesh, who is the anesthetist. So they referred me to your HOD one, Dr. Pradeep. And when I spoke to Dr. Pradeep, he said that you need to catch Dr. Girish. He's the right person to talk about it. So that's how we reached you through multiple sources. So it was very nice actually hosting you, sir, and it was a very nice talk, very thought-provoking, and what we are doing and how we are doing things. I think that's the message we took it. Thank you very much. I thank you on behalf of the Scientific Society of AVMC for delivering this lecture. And before we close, I would like to tell the participants, we are moving on with our journey with priority areas in public health. We are going into some area which is another new thing for most of us, like what is healthcare economics and how it is going to affect public health. So that is the topic for next discussion. And we have a very eminent speaker, Dr. V.T. Muralidharan. He is a professor and HOD of Department of Social Sciences, IIT Chennai. So he is going to talk to us or take us through this journey about healthcare economics, how it is impacting public health services today. So that is the talk for next week. I hope you'll all find time to join us for the next discussion. So we'll hope that we'll be back with another very interesting episode for with you. We'll be back with another very interesting episode next week. Thank you very much. And for the benefit of our participants, I would like to say all these are available in our AVMC Puducherry YouTube channel. So you just need to subscribe to the channel so that you would get notifications on any new videos we upload. And if we go by the chat box, there is a lot of people who have thanked you, sir. One Dr. Karuna Jadhav and one Amruta Joshi. So that is how we are putting this thing. Thank you very much, sir. We'll close this meeting. Bye-bye, friends. We'll see you next Friday.